Hi everyone, I'm Stephanie Glickman with the Family Centered Treatment Foundation. I'm currently the clinical director here at the foundation, and we wanted to bring a short presentation to you all today talking about family-centered treatment, just giving you a quick crash course to the model, and also talking about the Duke study. And I'm joined by Elizabeth. If you could introduce yourself, and then we'll begin with the informational webinar.
Sure. Hey, I'm Liz Snyder-Fickler. I am a senior research scientist at the Center for Child and Family Policy at Duke, and we have partnered with the Family Centered Treatment Foundation to lead a randomized controlled trial of family-centered treatment in North Carolina.
Perfect. So just to share a little background information about family-centered treatment, here's just a visual of where we are currently in the United States with other sites for expansion on the books. So we, the green areas is where we have some pending contracts. So just to give you an idea that it's not just a North Carolina centric model, we are nationally recognized as an evidence-based model. And here's the zoom into North Carolina to demonstrate that we're in a variety of MCO catchment areas, and here on the left-hand side is a list of the providers who are providing FCT. And I'll talk about those a little bit more further down in the training, just about the specifics of how to reach out to them. FCT has a theoretical framework based in eco-structural family therapy, emotionally focused therapy, and sensory-based trauma treatment. So it's built on this very heavy layer of looking at systemic and trauma work, and all of that is interwoven into the delivery of family-centered treatment with the families we serve. Again, that trauma treatment is fluid throughout. We focus on 4 phases of the model. The beginning one is the joining and assessment phase, where we're getting to know the families. This is about a month or so. Restructuring phase lasts anywhere from 3 to 4 months, where we're doing a lot of the practice and trying new skill development. The valuing changes phase is really where we're creating ownership for the families that we serve, because we don't just want to be a piece in the model, or a piece of time for the families. We want it to be something where the things that they're learning are going to be long sustaining and they're going to carry through. And then the last phase is generalization, of saying the families got it, they're making some significant changes, they've really put in a lot of hard work, and that they're at a place where they're ready to move on. So overall, the model lasts about 6 months. It varies for each family. We make it very clinically relevant based on each individual family's needs, but 6 months is about the time frame. And it's also an intensive model where we're with families at least twice a week for more than an hour every session, usually 2, sometimes 3 hours at a session. And like I mentioned before, we're looking for that sustainable change. So it's not just looking at the surface behaviors we want to see compliance with. We're going beyond to say, how can we implement any changes with new scenarios that arise and new family system changes and new dynamics that may happen. And so the more that we have families practicing new things and applying them to different circumstances, the more likely they'll be able to carry them through, to ideally have them not be so reliant on the overall system on an ongoing term. We're a blend of a lot of best practices. We include the whole family in the process. Our practitioners are scheduling sessions at times that meet the family's high need times. Some families it's earlier in the day, some families it's later, some families it's on the weekends. There's also a 24/7 on-call crisis support that each of the providers provide. And that treatment intensity, like I mentioned, is determined by the clinical need of each family. There's a lot of practice that we put into family-centered treatment. And so it's not just about giving them ideas and suggestions. It's saying, here's an idea, let's try it. and then let's try it again. And if this doesn't work, we're going to try something else. And we continuously are working with the families in a constant feedback loop of what worked for you, what didn't, how can we try this differently, let's do it a different way. So we really have the families' involvement with true experiential practice activities. So it goes far beyond like a basic talk therapy model. The trauma treatment that we see, like I said, it goes through all phases of the model. So we're looking at the very beginning of treatment. We're doing specific assessments that are looking at the areas of family functioning we're going to target. We're initiating a trauma assessment, the UCLA PTSD-RI. We have other internal assessments for the model that look at potential traumas that may have arisen in the past and how they're impacting the family system currently. Everything from parenting techniques and utilizing sensory-based work is all inclusive of having trauma awareness and trauma incorporation. The model is also very culturally inclusive in that when we're doing the initial assessments and getting to know the families, we're finding out their histories, their backgrounds, their influences, their cultural biases, all of that comes together to really make the strategies that we deliver to the families as relevant as possible. Here's a few of the distinctive features. I've mentioned some. There's the no eject, no reject policy. We do a family giving project with all of our families. So we're helping them to see that even though they've reached out for some assistance, by utilizing FCT, there's things that are so inherently valuable that they can then give back to others. And so that becomes a part of the treatment process. The families love doing it. We love doing it with the families. The family is really in charge of the process. They're leading it. There's feedback systems at every session where they're saying what worked and what didn't. We have fidelity measures based at different points of treatment where they're giving feedback as to how the model's going. They're helping us to determine when it's appropriate to transition them to the next phases. And the way that FCT is designed is that it's not just simply a clinical model, it's also paralleled on the larger scale of the implementation. So not only are our families going through a phased model for implementation or further services, every provider that is doing FCT in the community also has a rigid implementation structure. So because we want to ensure at the foundation that our providers have all of the tools and skills and that the staff have the training and education that they need. And there's times where we're doing reviews and audits with them just to make sure that they're on board and making sure that all compliance and fidelity is upheld. All of the staff go through an extensive training and certification process, which also then it goes through a recertification process every 2 years. So there is constant continual education that's happening for all of our FCT practitioners. And that brings us to our great outcomes. So this is some of our national data. The majority right now of our referrals are maintenance, where we're working to keep children in the home, and there's also, we're showing about 20% for that reunification. We're starting to see that percentage shifting a little bit, where more reunification cases are coming in, where there has been a child placed outside of the home that we want to bring back in, and we've had growing partnership with kinship care placements and foster care placements, and so we're hoping to continue developing that as well. You'll see on the bottom the referral agencies where we tend to get the referrals. And again, this is looking at across the nation of how the percentages lie. Here's just a peek at our 2018 outcomes. Shows that families who made it through all 4 phases of treatment, there was that 97% success rate. We ask families at the end of treatment, has FCT improved your family life? And 91% of our families are saying yes. And, the other numbers are just speaking for themselves. And so, it's one thing to say we have a great model and families like it. It's backed up by so much data, so much research, and we just want to keep that going. Here's another great example of specific feedback that families have given. This was looking at 663 families over a 3-year span. And again, the numbers are speaking for themselves, you know, that they feel like they were better able to handle their family problems, that they could depend on their clinician whenever they needed help. You know, I mean, these are really impactful and valuable numbers for us, because this tells us that the services are being delivered with the high fidelity that we want and desire, and that the families are getting the best care possible. And another snapshot of some outcomes for program completers over a 3-year span. And so again, 93%, 95%, and again, 93%. So families who completed all 4 phases of FCT, these were the successful outcomes at the end of treatment. And that was based on a study done by Indiana University. This just is demonstrating how we're very active in the Title IV waiver evaluation. There's a sub-study going on, and we are continuously involved with the Clearinghouse and the Family First Prevention Act and a lot of other national initiatives that are coming down. And safety, permanency, well-being, and family functioning. Here's where these are falling. You know, this is some of the language that we see on national levels when they're looking at comparing models of safety, permanency, well-being, and family functioning. And you can see from the various things noted in green where we're considered favorable and significant, and you know how our safety rating scale, we have conditional notings of conditionally safe. 86% demonstrated favorable results for children who participated in FCT. So the numbers are there, the numbers are supported, and we are very excited to continue bringing FCT to more families. And here's what's ahead. So we have the randomized control study, which Liz is going to go into much more detail with. We're initiating a family-centered recovery program, which is funded by the Duke Endowment, and one of our North Carolina providers is active in this, and so we're incorporating a substance use specific component with FCT. We have growing trauma-informed research happening, and like I said, we're heavily involved with the FFPSA. So lots of plans coming our way. And if you're in need or wanting any additional resources for family-centered treatment, here are some of the places you can go to. Our website is a great place to start and has links to all of these others. And we always welcome any questions coming directly to the foundation. So again, my name's Stephanie Glickman. My contact information can be found on the website, and I'm going to turn it over to Liz.
Thank you. I don't see, oh, okay, there we go. Okay, so I am going to be talking about the randomized control trial of family-centered treatment in North Carolina. So today we're just going to be talking about the parameters of the project that's being conducted with a target population of youths and their families who are 5 to 17 and a half years of age, who meet medical necessity for both family-centered treatment and residential level 2 or 3 out-of-home treatment. The partners for this study include our funder, who is the Duke Endowment, the Family-Centered Treatment Foundation, Cardinal Innovations Healthcare, Partners Behavioral Health Management, North Carolina FCT providers, as well as residential level 2 and 3 out-of-home treatment providers, our center at Duke, the Center for Child and Family Policy, as well as the Duke University Margolis Center for Health Policy. So the reason why we were contacted about leading a randomized controlled trial of family-centered treatment is that the existing evidence, as Stephanie talked about in her part of the presentation, is very promising. There have been quasi-experimental studies that have found positive outcomes with juvenile justice and child welfare specialty populations. And FCT has practice-based evidence with more than 15 years of data with the child mental health population. All of this has demonstrated very strong and positive outcomes for the model. But to date, there haven't been any randomized control trial studies done with the child mental health population. So RCTs are really the gold standard in research. It gives us the advantage of random assignment, which allows us to evaluate whether the intervention itself causes the observed outcomes. Random assignment into the treatment or control group ensures that there are no differences between the groups except for one. The intervention group participates in the intervention and the control group does not. If the study is properly carried out, then any possible difference in outcomes between the two groups can confidently be attributed to the intervention and not to other factors. It also, when we started this process back in 2018, and actually the planning started the year before in 2017, it was also a really ripe time to start this study because of the inclusion of FCT as a Medicaid approved or in lieu of service definition in North Carolina, which really presented a unique opportunity to partner with MCOs to study the effectiveness of family-centered treatment on youth and their families and caregivers. This will also allow for an evaluation of cost outcomes, so the cost of family-centered treatment as compared to an out-of-home treatment over time. And our center is leading a rigorously designed independent evaluation of FCT with this population of youth and their families. So our current study is the first RCT study with a focus on youth within the behavioral health care system. As I mentioned earlier, our target population are youths ages 5 to 17 and a half who are eligible for a level 2 or level 3 out-of-home treatment placement. The study goal is to determine if FCT relative to treatment as usual in one of these out-of-home placements leads to improved well-being outcomes for youth and their caregivers, improved family functioning, and decreases in overall costs of care for this population over time. So our study recruitment began in October of 2018, and it will run through June of 2022. We are currently working with 2 MCOs in North Carolina, Cardinal Innovations and Partners Behavioral Health Care. So our study has 2 components. There's an interview component with youths and their caregivers and an administrative data component where we will look at Medicaid cost claims over time for both behavioral health care and physical health care, but also education records, DSS records, juvenile justice records. Our sample size for the interview study is 375, where we hope to have half in the FCT intervention group and half in the control group. And our goal is to have 500 youths in the administrative data study portion. So our research team is recruiting and tracking these youth and their families for up to 18 months, even after treatment has concluded. So we will be tracking long-term outcomes for these 375 youth and their families in the interview study and 500 in the administrative data study through December of 2024. So youth who are eligible are between the ages of 5 to 17 and a half years of age who meet medical necessity for a residential level 2 or 3 out-of-home treatment placement and FCT. But it's important to note that not all youths are appropriate for randomization. So those who are excluded from our study are those with such significant safety issues that they absolutely cannot remain in the home, that there's too much of a threat to themselves or their caregiver or siblings in the home. Youth without an appropriate home environment to receive FCT. So for our study's purposes, we're defining home as having a primary caregiver. That can be a biological parent, a relative caregiver, kinship, or adoptive or pre-adoptive placement, who would be willing to participate in the FCT intervention. We also have to exclude youth who are currently working with an FCT provider right before possibly moving to a level 2 or level 3 out-of-home placement. And we also have to exclude youth with severe or moderate diagnosed developmental delays or other cognitive impairments. And that's because they have to assent to the interview process. And so we have to have at least an IQ over 65 for that to happen. Also, they must live within a North Carolina county where FCT service providers implement FCT. And then lastly, if there are safety or abuse or DSS concerns where the MCO knows that the youth cannot be in the home with their parent or guardian due to current safety as a result of abuse, but it's medically necessary for them to receive a level 2 or level 3 out-of-home placement, they would be excluded from the study since FCT would not be a viable option at that point in time. However, it's really important to note that for children in DSS foster care or kinship placement, we absolutely can include them in the study as they would have an identified caregiver who is not the abuser who could participate in FCT if they were randomized to that group. So randomization occurs at the MCO level within the utilization management division at each MCO. Our team at the center consults with these divisions on a weekly basis to help verify inclusion and exclusion criteria for study eligibility. And birthdays for youths serve as the method by which we randomize youth. So youth born on an even numbered days, such as September 2nd, are randomized into the FCT group, and youth born on odd days, such as October 11, will be randomized into the out-of-home treatment group. So in terms of what our interview study process looks like, families who consent to be a part of our interview study are asked to participate in a baseline interview and 3 follow-up interviews over 18 months. So they complete 4 interviews in totality with our research team. We do incentivize families and youth to participate. So with that first interview, they receive $95. The caregiver receives $75, and the youth receives $20. And the stipend increases at each follow-up interview thereafter. So $115 at the 6-month mark, $125 at the 12-month mark, and $165 at the 18-month mark. So if families participate in all 4 interview points, the caregiver and the youth together can earn upwards of $500 for participating in the study. We collect information about demographics. This is for both the caregiver, the family as a whole, and the youth. We also collect information about the types of services received and how well those services met the youth and family needs. We utilize the services assessment for children and adolescents for that part. For our outcome measures, we also look at youth and caregiver well-being. We use the ACEBA assessment system, the Achenbach system of empirically based assessment. We administer that at baseline and then every 6 months thereafter. So caregivers complete the adult self-report behavior checklist for themselves and the child behavior checklist for their child. And youth who are 11 and over complete the youth self-report. We also look at family functioning, and we measure this using the family assessment device, also done at baseline and every 6 months. That includes 7 scales, such as affective responsiveness, behavioral control, communication, problem solving, roles, and general family functioning. And then lastly, as I mentioned earlier, we are also looking at administrative data. So that includes Medicaid and other administrative data sources such as DSS, education records, and juvenile justice. So to just sort of summarize, the goal of this study is to determine if FCT relative to treatment as usual, which would be a level 2 or a level 3 out-of-home placement, since FCT is an in lieu of service for those out-of-home treatments, to see if it leads to improved well-being outcomes for youth and their caregivers over time, improved family functioning, and decreases in overall costs of care for this population over time. So how soon do significant improvements occur? How long do they persist? Are there decreases in primary costs? So do we see less Medicaid behavioral health claims or less expensive future claims? Do we see decreases in household income and burdens? And are there decreases in secondary costs? So those are the physical health claims, interactions with the Department of Social Services, increases in education, and decreases in interactions with juvenile justice. And so those are the questions that we hope this study is able to answer. So for every youth and family who is eligible for a level 2 or a level 3 out-of-home placement, giving families the opportunity to hear about the option of family-centered treatment instead of going to an out-of-home placement would benefit families tremendously, where they would be in the driver's seat to make the choice of what they think is best for their child and their youth, and to hear directly from an FCT provider about how this service could address the issues they're dealing with their youth and with their family in general.
Great. So thank you for your time today, and we hope to hear from you soon with any questions, concerns, and feedback, and want to keep this study going so we can get more quality services to the families in our community.